Thank you.
Thank you.
Thank you. Thank you so much. And thank you so much for having me back. My name is Yuanyuan. I'm currently the research fellow at the Irish Longitudinal Study on Aging, known as TILDA at Trinity College Dublin. And I did my PhD here in UCD, so it is really, really great to have the opportunity to be back on such a lovely day. And during my PhD years here in Geary, I always find this Geary seminar really, really helpful and inspiring for my research. So thank you again for having me back. And this is a co-work with my colleague Anne Nolan, who has been the research director of TILDA during the past 2 years. And even though now she's back to the ESRI, but we are lucky enough to still have her involvement in our TILDA research work. And she's really, really great. Having said that, all the difficult questions today will be directly to her. So today we are going to present the work on public healthcare entitlements and healthcare utilization among over 50s in Ireland, and I would like to start my presentation by explaining why we think this is an important and interesting issue. So we are going to answer 3 questions: why we think it is important to assess the public health care entitlements and its impact on healthcare utilization, why in Ireland and why over 50s. So why it is important to assess the impact of public healthcare on healthcare utilization, because uncertainty is a key feature of the healthcare markets. Health is inherently unpredictable, both in terms of financial costs and physical and emotional suffering. So this necessitates a role for insurance in offering the patient protection against uncertainty, and in reality, most developed countries provide publicly financed insurance for many health services for their populations, although there is considerable heterogeneity in what we call in the breadth and scope and height. So in terms of the breadth, we mean the extent to which different population groups are covered, and in scope, we mean what healthcare services are covered, and by saying height, we mean the extent of patient cost sharing. So in this context, it is important to investigate the impact of different types of health insurance on the health utilization, and we consider the public healthcare entitlements as a form of health insurance. So that's the first question, and if you do have any comments or suggestions, please don't hesitate to stop me there. And why Ireland then? Equity of access to healthcare is considered as a key objective of national and international health policy, and most countries subscribe to the principle that the financing of healthcare system should be in accordance with the ability to pay, and healthcare should be delivered on the basis of need. While in Ireland, we have a particular Irish system of the healthcare financing and the associated healthcare, public healthcare entitlement. The first main characteristic is that the Irish system of public healthcare financing relies predominantly on public sources of finance, with small contribution from PHI, private health insurance, and direct out-of-pocket payments by the patients. And the second characteristic is the crucial role of general practitioner, known as GP, in Ireland. GP provides a wide range of healthcare services in terms of the primary healthcare, but more importantly, they act as the gatekeeper for access to secondary healthcare in Ireland. So these are the 2 main characteristics of the Irish system of healthcare financing and the associated public healthcare entitlements that's associated with our research. But there are criticisms about the current Irish system on efficiency and equity grounds. So the first is associated with the GP. So although the proportion of direct out-of-pocket payments from the patients in the total financing of public health care is comparable to other European countries, but the amount of which is substantially higher than in some specific services, for example, the GP care. So the use of direct out-of-pocket payments for finance GP care by the majority of the population is very unusual in the European context. And given that given the crucial role of GP in the Irish healthcare system, we think investigating this is really important and interesting. And the second criticism is focused on the role of private health insurance, known as PHI, in facilitating faster access to public hospital services over those without a PHI but have equal health needs. So the current Irish system is criticized on the equity and efficiency grounds, and the major reform of the current system is outlined in the current program for government. And the two pillars in the reform, reform of the current healthcare system in Ireland are one, universal health insurance, known as UHI, and the second one is the free GP care. So this is the free GP care is outlined. So in the current program for government, it is outlined that the GP care will be provided for all at no cost at the point of use on a phased basis by age. So we'll start by children who age 6 and under, and then patients age 70 and above, and then those who age from 6 to 11, and then 12 to 17. So in this context, it is crucial to understand the likely demand implication of providing free GP care to the Irish population. So studying this issue in Ireland is important, and then why over 50s? The Irish population is aging. Although the Irish population is considered still a relatively younger population in the European context, but the Irish population is aging, and according to the CSO's prediction, by 2046, approximately 21% of the Irish population will be aged 65 years old and above, and about 7% will be aged 80 years old and above. So there are increasing concerns over the sustainability of expenditures on healthcare, and we think providing the this type of research focused on the population over 50s would provide insight for the current government's policies and things. So in this paper, we're using data from the Irish Longitudinal Study on Aging, known as TILDA. We focus on the impact of public healthcare entitlements on healthcare utilization among the over 50s in Ireland. So that's what we're going to do in this paper, and a little bit literature review. So there is a large literature on whether and how the health insurance cover or user fees would influence healthcare utilization, and there is a consistent set of findings across a diversity of settings in terms of time periods, institutional context, data sources, methods, and types of healthcare utilization. And the conclusions are that there are significant effects of insurance on the utilization of a variety of healthcare services. So in order to assess the effect of the healthcare insurance, the ideal setting of this is experiment. And the first experiment that was devoted to assess this issue is the RAND Health insurance expenditure project, which was conducted in the 1970s, and more recently there is an Oregon health insurance experiment conducted, and there is a vast literature just following these two types of study, but we don't have experiments that's common. So the majority of the literature, they still use the natural experiment based on exogenous government policy, and these two papers provide a very excellent review on the vast literature on this topic. And in terms of the Irish evidence, Lade and Lowland, they have a paper on this, provides a very good review on what we find in Irish context. And the two things that I would like to highlight in the Irish context is that the Irish evidence is pretty much focused only on GP services, and they find that those with full medical or GP visit cards have a significant higher number of GP visits. So this is what we find in Irish context. But there is little research on the older population. So pretty much all the literature, they're largely concentrated on the total adult population, and this is despite the fact that the older population, on one hand, they are heavy users of healthcare. On the other hand, there might be different factors more important in determining the healthcare utilization among that specific age group. For example, the limitations in mobility, insufficient social support, reduced access to health and healthcare information. So in terms of how whether the health insurance would have an impact on the healthcare utilization, this is what we find in the literature. But take a step further, we are naturally more interested in the effect of healthcare insurance on the ultimate outcome on individuals' health. But as for that, the evidence is less definitive for the causal impact on health. I think probably due to the time interval. Normally on the current studies, we don't have a sufficient long time period to actually observe the effect on health. And there is a new and promising literature growing really quickly nowadays is the offset effect within the different types of health insurance. So the findings is less definitive again. So there are positive effects finding in terms of the offset effects. So, for example, giving free GP care, would that increase the utilization of hospital or the utilization of number of medications, or would that decrease that? So the current literature provides less definitive results, and again, due to the short time period, but we will have a go on this as we go on this. And in this paper, again, we use data from TILDA and we focus on two questions, the change and the effect of change. So first, we are interested to know how have public healthcare entitlements changed for the over 50s from 2010 to 2012, and then what is the effect of changing public healthcare entitlements on the healthcare utilization. So in the presentation, firstly, we'll focus on the GP utilization, and then we'll expand our analysis to other types of healthcare utilization. And data, a little bit about TILDA. So I'm working on TILDA, so I'm using TILDA data sample. TILDA is a population-based, nationally representative longitudinal study of over 8,500 community dwelling adults in Ireland aged 50 and older and their partners. By community dwelling, we mean that we exclude those who are currently living in a nursing home or other types of institutions in our baseline in wave 1. And the sample was derived from a clustered random sample of all households in the Republic of Ireland. And in case some of you are using the other types of aging data worldwide, our TILDA sample study is modeled closely to the other international longitudinal studies on aging. For example, the US one, US Health and Retirement Study known as HRS, the Survey of Health, Aging and Retirement in Europe known as SHARE, and ELSA, the English longitudinal study on aging. And our TILDA sample contains a rich set of variables on the health and the socioeconomic circumstances of older people, and I will give you a more detailed explanation on what we have in the TILDA sample later on. And the eligible participants and their partners or spouses of any age were invited to take part in our survey approximately every 2 years. And our survey consists 3 parts. The first is what we call a CAPI, a computer-aided personal interviewing, which takes about 2 hours. And the second part is what we call a SCQ, the self-completion questionnaire. So during or after the interview, we leave the questionnaire to the respondents to and ask them to finish that and return them back to us. The purpose of the SCQ is to gather more sensible information, for example, information on the quality of their relationships, their mood, and their feelings. And the third part is the health assessment. We're really proud of our health assessment part. So this is a research nurse-led health assessment, which takes about 3 to 4 hours. So we have very detailed, objectively measured on response each and every, on about 75 5% of the respondents, of the CAPI respondents, their health conditions. So wave 1 takes place approximately in 2010, from October 2009 to February 2011. Wave 2 takes place between April 2012 to January 2013. And in this particular analysis, we exclude individuals whose annual GP visits exceed 52 times and individuals who are younger than 50 years old at the time of the wave 1 interview. And to
how do they measure the annual GP visits? Is it how many times you've seen a GP in the last 12 months?
Yes, we ask them that. So to give you a more visual explanation of the TILDA timeline, so the blue period indicates when we collect our data sample. So this is when we collect TILDA wave 1, and this is when we collect TILDA wave 2, and this is when we collect data wave 3. The good news about wave 3 is that we are approaching the end of data collection. I think we will have our wave 3 data in a couple of weeks. So it is very good in terms of a longitudinal study aging. And the other things actually is telling you because the past few years is a very special period of the Irish economy, because we are in an austerity period. So there are many policy changes. So if you are interested in investigating the effect of these policies on older people's socio-economic circumstances and other related outcome, TILDA will be really good data to go. And I do have some pamphlets here, so if you're interested. For example, so in terms of health, so we do have the automatic entitlement to medical cards for the over 70s removed, starting from the January 2009. And we do have the emergency department's public hospital inpatient and prescription charges increased. And then we have, I think we have one at the, pension. So the annual earnings limit for pension tax relief is reduced. So we have all sorts of public policies, and if you're interested. And then coming back to our paper on public healthcare entitlements and healthcare utilization, how do we define the public healthcare entitlements? So currently, we can divide the Irish population into the following 4 exclusively groups. So for people who have medical, and based on the 4 groups, we can categorize them again into the 2 groups. So public, category 1 public and category 2 private, and those 2 categories are the main categories of the public healthcare entitlements in the Irish context. So I'll explain why we call them the first public and the second private. So the first category is what we call a public category, and patients in this category we call them public patients. So likewise, we call patients in this category private patients. So the public patients, they are full medical or GP visit card holders, and some of them may have their own private health insurance, in which case we call them dual cover. Some of them, they don't have the PHI. But the main thing is that for this group, they have the full medical card or GP visit card. And for the category 2, we call them private patients, so they don't have medical or GP visit card. So some of them, they may have their own PHI, private health insurance. Some of them, they don't have anything. They don't have medical card, they don't have GP visit card, and they don't have PHI. And for this type of patients, we call them patients with no cover. And this is a table explaining further on the actual entitlements of the different categories, and would explain why we call some of them public and some of them private. So in terms of GP user fees, so if you are a public patient, that meaning that you have a medical card or GP card, regardless of whether you have PHI or not, visiting GP is free. But if you are private patients, meaning that you don't have a medical or GP card, so even if you have PHI or you don't have anything, you have to pay the full cost at the point of use. Reimbursement is another issue. So at point of use, for the public patients, it's free. For the private patients, it's full cost at point of use. And in terms of the prescription user fees, For the public patients, it's 250 euros per item and 25 euros per family per month. But for the private patients, it's full cost up to 144 per family per month. So again, between the public and private patients, there are large differences in terms of the cost. And in terms of the public hospital care, again, for the public patients, it is free. For the private patients, it's subsidized. So different types of private patients, they might have the degree of the subsidized portion will be a little bit different, but it's not free. It's subsidized. And a note here is that medical card holders and GP card holders, they have different entitlements. Okay, so for the GP visit card holders, they have the free entitlements to GP care, but they have the same entitlements as the private patients in terms of the public hospital care and prescription user fees. But because in our sample, the GP card holders the proportion of the GP card holders is so small, it's less than 1.5%, so we aggregate them into the full medical card. Okay, so, and a little bit more on the institutional background. So how do we decide who gets the medical card, who gets the GP card, and who gets nothing? So the eligibility for for GP card or the medical card is assessed primarily on the basis of an income means test. And if you're interested in in the actual threshold, there is a document here which will show you the income threshold, and you can easily Google this and here. So you can easily Google this on the internet. So there are different thresholds for different age groups. And one thing that I need to emphasize here is that in terms of the income thresholds, besides the age differences, so the income threshold for the GP visit card is 50% higher than the medical card. And there are, besides the majority of the GP and medical card holders get their card through the income means test, but we do have very small proportion of people who get their card by discretionary reasons, mainly by health reasons. So, as I said, the first focus of our paper is to see how has the public healthcare entitlement changed for the over 50s in between the two waves. And this figure actually shows how it changed. So wave 1, we have the 4 categories, and in wave 2, again, we have the 4 categories. And this number is actually the number of respondents in each category. So we have individuals who are both in wave 1 and wave 2, and who are older than 50 years old at wave 1, and the final sample size is approximately 7,000 in our case. And for those the color in blue, they were public patient in wave 1, and they remain public patient in wave 2. And for those in red, they were public patient in wave 1, but they became private patient in wave 2. And those in purple, they were private patient in wave 1, but they became public patient in wave 2, and those in black, they remain private patients from wave 1 to wave 2. So we can actually observe transactions there. And another observation would be the number on the diagonal is quite large, because it's large proportion of people, they stay the same status as before. Okay, so as I just said, so there are two main transitions that we're interested in this analysis. So we would like to investigate each and every transition, but due to the small sample size, at the end we decide to aggregate some of them together, and that's why we have the following 2 transitions. So we have the transition 1 is what we call a gaining transition. So people who were private patient in wave 1, but in wave 2, they gain they became public patient, they gain free access to GP and to GP care. And the other transition is what we call a losing transition. So for this transition, we refer to the people in this group. So who were public patient in wave 1, but who became private patient in wave 2. So these are the two transitions or two treatments that we are interested in. So treatment 1 is the gaining public health care entitlement. So we focus on the people who were private in wave 1, but who became public in wave 2. And on the contrary, we have people who lost their public health care entitlement, who transform from public to private in wave 2. And we will analyze the effect of gaining and losing separately. And to take that a step further, we will analyze whether there is a symmetry in the effects. So is the effect of gaining a full medical card the same as the effect of losing a medical card or not? Okay, so our aim is to evaluate this treatment effect. So ideally, we would, if we have experimental data with random assignment, like the RAND-HIE project, it would be really good, because then we just need to compare the outcome, and averaging over the sample will give us an unbiased estimate of the treatment effect. But like many other studies, TILDA is an observational study, so what we have is observational data. So we can note the problem with the observational data is that we cannot observe an individual in both treatment and control status. We can only observe one status, the individual in one status, and we cannot observe the counterfactual status. And here we have a problem of selection bias. So individuals are not randomly assigned to treatment and control groups. And in this case, if we still just comparing the outcomes of the people in treatment and outcome variables in treatment and control groups, we would end up getting the biased estimate of the treatment effect. Okay, so one solution to this, one attempt to this would be using the propensity score matching method. So instead of comparing all the people in treatment and the control group, we just compare the outcome of the treatment individuals with those of matched individuals. So we compare individuals who are similar pre-treatment, and then we compare their outcomes. So how do we match them? We match them on the propensity score, the predicted probability of getting treatment. And we use a variety of measures of proximity to match treatment and control individuals. So we'll start with the nearest neighbor, and we'll continue with kernel. And this figure gives you a visual explanation of the propensity score matching. So this is the propensity, so the predicted probability of getting treatment, and this is the change in the GP visiting. So, and for example, S stands for the people in treatment group, N stands for the people in the control group. So without any matching, we just simply compare the outcome between the treatment and the control group. We will have an observed difference between them. For example, if we just compare people who are who gain medical card and the people who stay private, we can get an observed difference. But that difference is not what we are interested in, because the difference between the observed difference in GP visiting might due to the fact that one get GP card, one get a medical GP card, the other one didn't get a medical GP card. Or it could also due to the fact that they have different health care. So there are other factors in the picture, and we need to clean them, we need to exclude them in the picture by we perform a matching in the first step, and then we just compare them in the second step. So we using a large set of observable of variables, we just match them first, and we make sure that the individuals here and individuals here, they are comparable in every observable way before the treatment, and then we compare the outcome between them, assuming that the only difference between them is that group get treatment, that group didn't get treatment. Okay, so to repeat, we have two treatments. So we have the gaining treatment and we have the losing treatment. And explaining that a little bit further, so we have the first treatment as the gaining treatment. So that's for the people who gain public health care entitlement. So for the treatment group, is the individuals who were private patient in wave 1, but who become public patient in wave 2. The control group for that group would be people who remain private in both waves. So they start at the same status, being both being private, but at wave 2, the treatment group become public and but the control group stays private. So in our TILDA sample, we have about 450 individuals in the treatment group, and we have over 3,000 in the control group in this case. And then we have the losing treatment. So the losing treatment group would be people who were public patient in wave 1, but they became private patient in wave 2, and we have about 100 of them. And the control group of that would be the people who remain public in both waves. So they start the same in wave 1 being public, but in wave 2, some of the treatment group become private, but the control group stays public. And we have over 3,000 observations for this. And as I mentioned, so the outcome variable, so that's our treatment. So the outcome variable in our case, is the change in the number of GP visits per annum between wave 1 and wave 2. Okay, so in the CAPI, we ask in the last 12 months about how often did you visit your GP. This captures the number of GP visits in the last 12 months, and we have this variable in both wave 1 and wave 2, and we take the first difference between this. By doing this, we are we are trying to solve the potential bias problem that the simple propensity score matching estimators would have, because the simple propensity score matching's assumption is that based on the propensity score that we evaluated in wave 1, the individuals in control group, they would have similar GP visits in 2 years' time compared to the people in treatment group if they had treatment. But there are, as I mentioned, there might be other time variant factors that's going on. For example, the health changes and health shocks. But by using the first difference in outcome variable, we are kind of combining the DID in a propensity score matching setting because now the assumption would be based on the propensity score evaluated in wave 1, the individuals who are in the control group, they would have similar changes in their GP visiting compared to those in the treatment group if they had the treatment. Okay, so this would be a step further in attempt to solve the bias issue here. And this is the distribution of GP visits in the TILDA sample. So the average number of GP visits for wave 1 is about 3.8 per annum, and the average GP visits in wave 2 would be about 3.9 per annum. And we can observe there is some heaping evidence here. So individuals tend to report their number of GP visits by half a year, like 3 months or a year. Okay, so that's quite common, self-reported number of GP visits. And this is the raw difference between the treatment and control group in terms of their average number of GP visits in wave 1 and wave 2. So here is the results for the gaining subsample, and here is the results for the losing subsample. So the first thing I want to say is that there are significant differences between in both treatment in terms of GP visiting. So for those who gained their medical or GP card, their number of GP visits increased by about 1.4 times per annum. And for those who lost their GP card, their GP visits number decreased. So there are significant differences, and the direction of the change is in our expectation. And the good news is that in the control group, the number of GP visits, they don't change that much in both waves because their GP or medical card status didn't change during the 2 waves. But one thing that worries us a little bit is the starting point for the treatment and control group. They are a little bit different. Okay, and that's why we need to take a step further to match them together first, and then to compare the outcome between the treatment and control group. So, as I said, we need to match the individuals in treatment and the control group to make sure that they are similar as possible, and then compare the outcome between them. So we explore a set of variables to match them. So the following 4 aspects: demographic, socioeconomic, health, and objective health measures. So in terms of demographic, we use age, gender, and marital status. In terms of the socioeconomic status, we use employment status, income, education, household location. And because we are analyzing the population over 50s, so we think it is important to include those two variables that might be more important for the over 50s. One is whether the respondent has kids. The other one is the Berkman-Sim Social Network Index. It is a very commonly used index for measuring the social network. It includes 4 aspects: with the marriage status, close relationship with children, relative or family, whether you are a member of a church or whether you are a member of a voluntary group. And then for the health needs, we have the self-reported health status currently and in childhood. We have the information on parental survival. We have the chronic illnesses, so which includes about 14 different types of illnesses. And we have an indicator to indicate whether the respondent has problems for activity for for the ADL and IADL. That measures the daily activity. So whether you have problems in terms of your daily activities, or for the ADL, it measures things like whether you can run whether you can jogging, whether you can walk for 100 meters. For the IADL, that's what we call an instrumental average daily activities. That's something like whether can you feed yourself, whether you can take the bath yourselves. And then we have the CSD measures on depression, and we have information on smoking and drinking. So drinking, we use the CAGE. So CAGE is a commonly used indicator for problem drinking. So it has 4 questions here, and basically, if you answer yes to 2 of them, you would be categorized as having a problem of drinking. And the key element in that is that have you ever feel that you really need to drink in the first thing in the morning to actually start your day, as known as the eye-opener question. And as I said, one advantage of TILDA over the national and international studies, actually we have objectively measured health status on respondents. So here we're going to use some of them. One is the BMI, the body mass index, and then we do take respondents' blood pressure during health assessment and their blood sample for testing whether they have high cholesterol, and we have the TARC. This is my favorite. So TARC in seconds is a really good way to measure the respondents' physical functionality. It measures the time in seconds that that takes for a respondent to stand up from a chair, walk for 3 meters at their usual pace, turn around, walk back, and sit down. So it's a really good measure of the respondent's physical functionality. And all these measures, all these variables, they are measured at wave 1. So essentially, we are matching them at their wave 1 characteristics. And this is the results. This is the results of the changing public healthcare entitlements on GP visits. So we measure them on their wave 1 characteristics, but we take the first difference on the number of GP visits. Okay, so column 1 and column 3 are the treatment effects when we exclude those objective health measures. Column 2 and column 4 are the results when we include the objective health measures. So we know the objective health measures is really important in matching the individuals in as best as we can. But as I mentioned, only about 75% of the respondents in our sample that they actually went into the health center and did the assessment. So that would cause us the loss of sample size. So that's why we did both. So, and kernel matching is good in the situation like this where we have numerous control variables for the treatment group. So we'll focus our results on the kernel matching. So, and for the gaining subsample here, so whether we include or exclude the objectively health measures, the treatment effect of gaining medical or GP card is quite consistent and significant. So gaining a medical or GP card is associated with about 1.3 extra GP visits per annum, while on the other hand, the effect of losing is less significant and there is larger differences between the estimates when we exclude and when we include the measures. So losing a medical card is associated with about 1.2 less GP visits per annum. And if we compare them to the starting point, like the table that I showed before here, so if we actually compare the change of the magnitude of the change and the magnitude of their GP visits in the first wave, we can say that 1.3 extra GP visits is about 43% increase based on their initial GP visits in the baseline, while 1.2 less GP visits is about 25% of their initial GP visits level in the first place. And this is the results for the GP care, and this is the figure actually showing you how good the quality of the matching. So the dots actually shows you the differences between the treatment and the control group in each and every variable that we include in our matching analysis. And we can see that before the matching, the differences is huge, but after the matching, so it is relatively good, so it's close to 0. So the cross actually represents the difference between the treatment group and the control group after matching. And this is for the gaining subsample, and this is the case for the imbalance test for the losing subsample. So matching is doing a reasonably good job here in our case. And then to further...
Sorry, can you just clarify?
Yeah.
All your fancy matching hasn't really changed anything. Like the raw difference is the same as the matching estimates. Yeah. About 1.3.
It's...
If you just take in the simple difference.
Yes.
If you stop there, you'd have got the same answer. Basically.
Yes. Yeah. Yes. So we don't observe quite large differences between the raw differences and the matching one.
So one concern with the matching, I mentioned this before, is that if you get people identical before the treatment, so they're the same age, they're the same income, they're the same health levels.
Yes.
Then almost certainly the reason someone lost a medical card and someone else didn't is because they got some negative health shock,
yes.
income shock, and lost their job. So it seems they're very endogenous things. So if there are direct effects of an income shock or a health shock or an employment shock on your health utilization, is that a problem?
Yes, thank you. So you mentioned this problem to me before, and one way I did a little bit sensitive test on this to simulate the ATT, assuming that there is an unobserved omitted variable that whose statistical properties mimic those one of the included one. But another thing that I did do was I actually compare, I don't know whether this can answer your question or not, I compare the characteristics across waves for treatment group. So this table actually shows you the characteristics only for the gaining, for people who gained their medical card, and those are the characteristics for in wave 1 and wave 2, and because I have a very long list of characteristics, I only report those who have significant differences between waves. So all the other variables, they are not significant different between waves, but only, as you mentioned, only the employment status and the health status. But in this case, we can observe that people who gained medical cards are not necessarily due to the health shock. So their health condition is is deteriorating. On the other hand, their health situation is not necessary.
I think that's good. It'd be good to see it for the match sample. Is this a match sample?
Yes.
Okay.
Yes.
Okay, so why are they getting medical cards then?
Employment status, their income. So it is essentially an income test. So the medical card, the eligibility for medical card is primarily assessed on the income test. So we do have discretionary basis for granting GP or medical card, but the proportion is really, really small.
So the other point to make is that these are observable health characteristics.
The
here.
self.
You know, there could be something else that's driving change in medical card status for discretionary reasons.
We do have information on hypertension and BMI, that stuff, but we don't have specific health conditions. Yes. Yeah.
But the other thing you could do would be quite simple. It's sort of regress change in GP visiting on things like change in income, change in employment status, change in health status. That's
actually what we're doing now. So after this paper, we're saying that matching is a good starting point. We are actually modeling that now. So using...
Right, but that will give you a quick back at the end little thing. Because I suspect you find changes in income have very little effect
on the
GP utilization.
It is significant, but I cannot recall the magnitude of the income at this.
You can probably get a good sense of how big the bias could be.
Yeah. Yeah. Thanks.
Well, change in employment explains some of it.
Yeah.
How more time free working on what use.
Yeah. Yeah.
So, I mean, you've got these multiple things going on.
Yeah.
Yeah. Using eligibility for a particular reason.
Yes.
So,
yeah. Yeah. Yeah, and the employment status is a fairly good indicator for income levels as well. So, and we do that for the losing subsamples again, employment and health status.
How is the depression scale scored? It falls. The depression score falls. Does that mean that they're less depressed or more depressed?
Less.
So they're less depressed.
In wave 2.
It's kind of puzzling.
It is. It is. It is. So, any explanations on this and suggestions on this would be most welcome.
Right, because you might have thought that the causality there, they lose a job, and there is, it's well established that unemployment has negative health effects.
Yeah.
So they lose a job, they get more depressed, they get worse health.
But yeah, I think that's probably normally the case. But so during the past 5 years in Ireland, I constantly be amazed by the cheerful spirit of the Irish women. And during our TILDA survey, even we ask a man who just lost his leg, we ask, how do you feel? He answered, I'm grand. So, and the score is actually is a 20-item question. So we do ask the respondents how do they feel. So their feelings and emotions. So probably it's just because we are cheerful. So, but it is puzzling in this case. And going back to the GP here. So the further discussion. So because we know that the propensity score matching and even the DID, we take a little bit element on the DID, there is still a possibility that there is an omitted unobservable variables that could lead to both the changes in whether they get a medical card or not and their healthcare utilization. So in order to deal with that problem, we perform a sensitivity test, which is essentially a simulation. And then, because the current Irish system, so people who age 70 years older, they have a very high income threshold, and approximately 90% of the Irish population age 70 and above, they do have a medical card. So we do restrict our sample to people who age between 50 and 69 to see whether there are significant changes in terms of the effect. And we do analyze the effect of changing public healthcare entitlements on other types of healthcare utilization. So in terms of the number of emergency visits, the number of outpatient visits, the inpatient hospital nights, the number of medications they take, whether they take a flu vaccination or cholesterol blood test. Okay, so as for the sensitivity test, it is a simulation. So basically, we assume there is a omitted variable, that unobserved variable that that is in the picture, and we try to simulate the effect of that omitted variable under one assumption, is that the statistical property of that omitted variable mimic one of those included variable here. So first thing we can see that, so this is our propensity score matching estimates using the PS-match2 commandings data. So this is our original treatment effects, and we can observe that if we simulate the unobserved confounder whose statistical properties mimic the following variables, the first thing we can say that there isn't much change going on there. So this indicates that our estimates are probably good in this case. And how I choose, so I have a list of variables here, and how I choose these variables. So the variable I choose so the variables will be here if the difference in this variable between the treatment and control groups are significant. Okay, so I only choose the variables that has significant difference between the treatment and control group, and we can see that there isn't much difference going on there, which is good news. And the second sensitivity, or the second thing that we do, is we restrict the sample to people who age only 50 to 69 years old, and to see whether there are big changes in terms of the treatment effect than before, and we can observe less increase in the gaining subsample here, which makes sense because they're younger. And then we try to estimate the effect of changing public healthcare entitlements on other types of visits. Nothing going on there in terms of the emergency department visits, nothing going on there in the outpatient visits, and almost nothing going on there in the inpatient hospital nights there. But we do observe a significant increase in the number of medications that individuals use. Okay, so if you gain a medical card, there will be an increase of about 0.3 medications that you use here, but nothing going on there in the losing subsample. And I didn't report the results for flu vaccination and cholesterol blood test here. They're not significant here. And so we're running out of time to wrap it up. So using nationally representative data from the Irish longitudinal study on aging, our results indicate that there is a significant relationship between the public healthcare entitlements and healthcare utilization among over 50s in Ireland. Gaining is associated with about 1.3 extra visits per annum, which is about 43% in the number of annual GP visits for those who gain their medical card, while losing is associated with about 1.2 less visits per annum, which is about 29% in the number of GP visits for those who lost their GP or visit card. And there is not much going on in the offset effects, so no significant impact on emergency visits, outpatient or inpatient visits, significant increase in the number of medications for gaining, and no significant impact on preventive healthcare. So this is relatively new literature, and we do this using the same modeling techniques as we model the GP visits. So we're still wondering whether this is an appropriate way to do this. So any suggestions or comments on this would be really helpful. Thank you. And there are a few caveats. So first, we didn't observe all the possible transitions due to the sample sizes. So with further waves of data coming along, we hope we can do a little bit more about that. And then there is still a possibility that the differences in time varying characteristics between waves that we don't observe actually might driving the change in the healthcare utilization. So what we observe here is probably the upper bound of the effect. And then, in order to fully evaluate the impact of the changing public healthcare entitlements on total healthcare expenditure, we also need the assessment of the impact on health, on potential supply side effect. So we only have the information on patient side. We don't have any information on the GP, on the doctor side. So it would be really important to have potential supply side analysis and potential offsetting effects among the different types of health utilizations forms. But this is a timely research because of the current program of government and the free GP for all is going on. We already have free GP visits for children under 6 and for individuals who age 70 and above. And we do hope that this analysis would provide insights for policymakers in the Irish healthcare system. And those are the founders and our associate partners in the TILDA study. And thank you very much. So those are the email address for Anne and myself. So if you do want to use, thank you.
Okay. We have about 5 minutes left.
Sorry.
For any questions.